I will let Dr. Jonathan Bingham introduce himself, even though you can't see him
Oh,
right
we
now.
can see him again.
Oh, you can? Okay.
You're back to your video camera view.
Perfect. All right. Well, hello, everyone. As Dr. Riggs had mentioned, my name is Dr. Bingham Jonathan. So I'm a second-year resident at the Cox Health Family Medicine Residency. I also have the pleasure of having my continuity clinic through Jordan Valley. So I get kind of to work at both locations, get to experience a little bit of both, okay? I've worked with some of you. I recognize faces in the crowd, worked with some of you, but I'm sure I'll be seeing others of you around as well, kind of rotating with us and things like that. So today I understand where you all are kind of at in your mental space right now. Just had a shelf exam, kind of a little bit worn out. So I didn't want to hit you with a bunch of hard facts or anything that's going to kind of wear you out more. I figured we could just kind of have a conversation and talk about what does it look like to discuss controlled substances with patients. Because this is a ever evolving topic. There's been major shifts in, the view of controlled substances over the past decade to 2 decades. Initially, these medicines were looked at as, in a sense, wonder drugs with how well they treated pain and how well they treated anxiety and the things that they did. And then we learned how addictive that they can be and the harm that they can cause to people. And it shifted over to demonizing controlled substances and making it to where no one really wanted to prescribe them. No one wanted to be involved with the prescribing of them. So I land somewhere in the middle there. And I think that that's where we ultimately need to be as medical professionals. So I just wanted to kind of go through a little bit of this and give you all a little bit of an approach to these patients that may be taking controlled substances. Okay. So a little bit about myself. So I did my undergrad education at the University of Missouri in Columbia. Grew up in Kansas City, was born and raised there. For medical school, I did go up to A.T. Still University in Kirksville. I did a osteopathic manipulative medicine fellowship there in between my second and third year. And then for residency, like I mentioned, came down to Springfield, joined the Cox Health Family Medicine Residency, and now the first official chief of the Jordan Valley Residency that's now newly opened this year. So get to kind of work on evolving that residency and helping it become, what we want it to be. So, all right. So alluded to this a little bit, but I found some pretty shocking facts and glaring facts that I think kind of drive my point home. So why does this topic matter so much, right? So the big thing we always hear about and learn about is addiction and abuse, right? So when I initially thought about addiction and abuse, you initially think about street drugs, right? So these people who are out seeking medications without a prescription, abusing them, things like that. Well, it turns out that 2.7 million individuals starting at age 12 or older have an opioid use disorder, and 2.3 million of those, it started with a prescription, right? So that leaves about 400,000 people otherwise, but as we're not all mathematicians, I didn't get into this for math, but you can tell that's a huge proportion that was started by a prescription by a doctor for a legitimate reason. So death rates, so they don't have updated death rates since 2022 because they're a little bit hard. Most of these people, if they do die of overdose, it is of polysubstances, so it's a little bit hard to tell. But in 2022, there was a total of 107,000 drug overdose deaths, and about 81,000 of those were related to opioids or controlled substances. So pretty significant amount. And then this one I thought was really interesting. So burden to the health system. So we all know that chronic pain is one of the biggest reasons that people come into primary care offices and things like that. But if you look at the cost of treating chronic pain and diagnosing it, it was $100 billion in 2022, and that surpasses the combined expenses of both cancer, diabetes, and heart disease together. So this is something that's not going away anytime soon, and it's something that we need to recognize is costing a lot of money for us to do. And some of that can be linked to shying away from the use of these medications in acute instances. So, okay. So let's back up a little bit and say, well, what is meant by a controlled substance, right? So this term colloquially is looked at as bad, as negative, right? So all this term means is that this drug is subject to scheduling due to potentials for misuse and addiction. That's all it means, is that there's a potential there. Some have higher potential than others. So controlled substances, as we define them, include all opioid analgesics, sedatives, hypnotics, and stimulants. So, so that may pose the question in your mind, well, what goes into scheduling these drugs, or what is the thought process in scheduling drugs. And here are some of the kind of questions that they look at whenever they're deciding should a drug be scheduled, and if it's going to be scheduled, how high should it be? So, and as you can see, a lot of this revolves again around misuse and abuse, so. So let's look at some different schedules, because this is something that you all may be tested over. It's been a while since I taken my level 1, but I think it was on there. So Schedule 1 drugs, this is your highest potential for abuse, and there is no currently accepted medical use. So a lot of these are the street drugs that we've kind of talked about. So heroin, LSD, THC is still Scheduled 1, even though it is legal in Missouri. Ecstasy and peyote as well. So as you go down the list, you'll notice a trend. Essentially, it becomes less potential for abuse than the level above it. And then anything Schedule 2 or lower, there is a currently accepted medical use. It just may be more specific than just general use, right? So cocaine, one of the things that I learned that that's used for is in ENT surgeries. When they do sinus surgeries, it is a very good vasoconstrictor. So they often use that in those surgeries. And common pain medications, so morphine, Dilaudid, oxycodone, fentanyl, those all fall into that Schedule 2.
Do they have to tell the patients before they give them?
They
cocaine?
do, yeah, they do, and they mark it 3 or 4 times in the operating room, so it's very clear that that's what's being used, so. So Schedule 3, so again, less potential than for abuse than Schedule 2, and has currently accepted medical use. So Tylenol 3 is one that falls in that category, as well as ketamine and anabolic steroids and testosterone. So Schedule 4 is where our benzodiazepines and Ambien land, and the less potent of the kind of opioid pain medications, Tramadol. And then Schedule 5, the ones that I most commonly see used down there are codeine, cough syrups, and Lyrica. So that's kind of what we look at whenever we're talking about tiers of schedule.
Before you go too far, I am gonna share the screen.
Okay.
Is that better?
Yes, thank you.
Yes, thanks.
All right. Let's talk about the major challenges that you're going to encounter whenever you're having this conversation with patients, right? So I think first and foremost, the biggest one that I get is patient expectation and pressure, right? So patients come to you, their previous provider was prescribing this medication, no questions asked. They got every 3-month refills. They only had to come in every 3 months for a drug screen. You know, they know in their mind how they should be getting the medication, right? One thing that I've learned in residency, and one thing that I've learned is that, you know, you are the one practicing medicine, right? You're the one that has a license. Just because a prior provider was prescribing something the same way does not mean that you have to continue prescribing it that way. However, patients are going to frame it that way, right? Well, so-and-so gave you this medication and didn't have a problem with it. Why do you have a problem with it? So having in the back of your mind your reasonings in mind before you go into the room and before you speak with the patient really helps you to kind of curve around those and explain to them why you have a different opinion than the prior provider that they had. Stigma and bias. So a lot of these patients kind of self-reflect on themselves, and they know the outward reflection that being on these medications poses to people, right? I've had patients call in for refills and they say, well, I don't like calling in for refills because it makes me feel like a junkie, right? They don't want to feel like they're addicted to these medications or that they're on these medications because they know of how society looks at that, and they don't want to be pinned as that person if they have a legitimate need for these medications. So balancing empathy with caution. This one is one that I feel is really hard for us all as medical professionals, right? Most of us got into this profession with a big heart and a desire to help people to end pain and suffering, treat the things that we know that we can, right? And so when you see a patient in front of you that's experiencing those things, it's hard to, you know, to break away from those, the tugging at the heartstrings and realize that there is potential for risk and potential for harm in prescribing these medications, despite the fact that you know it will give them pain relief or it will help them with their anxiety and things like that. So recognizing that you can have empathy, but you need to be cautious with how much you let that rule your judgment. And then last but not least, the ever so worrisome limited appointment time. These conversations can be very long and very in-depth. My appointment times currently in residency, I get 20 minutes per patient. So that's with rooming, seeing them, doing your assessment plan, everything. You can imagine this conversation alone could take 30 minutes plus just to have this conversation and explain to them and come to an understanding. So keep that in mind. There needs to be a lot of pre-planning. And a lot of really good understanding prior to going to the room so you can limit how long that conversation takes.
It's not gonna work now. Karen, how
There we
about
All right.
that?
So here's our general approach. So kind of a 6-step approach. I tried to come up with a good mnemonic or acronym or something for us because I know that's how we all remember things. Couldn't figure that out. So maybe one of you all are smarter than me can help figure that out. But so build rapport, and we'll go through each one of these in kind of detail and explain a little bit of like how you would do it. So building rapport is huge. Getting that patient to feel like you really care about them, their experiences, their past, and everything really helps them to trust you in your decisions and your conversations going forward. Assessing the need. Always make sure that you're assessing whether or not this patient needs this medication, right? So there's lots of evolving guidelines and lots of new treatment modalities and things that have been shown to be as effective, if not more effective than some of these medications. And so make sure you're always being up to date on treatment standards of care and really making sure that they still need that medication. So setting boundaries and expectations, again, making sure that you know where you stand in your practice, what you're okay with, what you're willing to prescribe, and your kind of guidelines around that. And we'll kind of explain a good way to go about that. Handling difficult conversations. Inevitably, patients are going to get upset if you don't prescribe them medications. If their medication runs out, they don't call in early enough and they don't get their refill soon enough, there's going to be problems. You have to know that going into prescribing these medications for these patients, so be prepared on how you're going to deal with those when they arise. Collaborating with others. We're going to do an IP case after this as a perfect kind of example of this. So in chronic pain management or controlled substance management in general, is really important to rely on your colleagues, whether that be pain management specialists, psychiatrists, psychologists, behavioral health consultants, every tool that you have in your toolbox to try to help this patient as best you can. And then always say no when you need to. If something's giving you, a bad vibe, something's making you feel like this patient is misusing this medication, something is just not right about this medication, you can always say no. Now, there are safe ways about doing that, and there are certain ways that you need to taper medications and things that you need to take into consideration when saying no, but that is ultimately always on the physician that you can say no if you feel like this is unsafe. All right. So building rapport. So this is something that you get taught, through my medical school, they spent a lot of time getting us to just be good at taking histories, right? And getting to know the patient, getting the patient to trust you, right? So always using open-ended questions, right? You don't want to guide a patient to an answer. So here's some examples of kind of ones that I had come up with that are usual good ways to just start the conversation, right? Like, what events led us to where we are today? How did we get to where we are? How did we get on the medications that we are today? And that can encompass, medications and therapies they tried in the past, injuries that they've had, traumas that they had, anything that may have led them to this point. Avoiding judgmental language. So that one's huge. Again, these patients already know that there's a stigma and a bias around these medications that they're taking. If they sense that you're judging them or that you have judgment in your verbiage that you use for them, they're going to create a barrier. They're going to be put off of you as a provider. And if you're ultimately trying to help this patient get off of these controlled substances, then that's going to make it a lot more difficult in the long run. And then showing empathy and validating concerns. Again, oftentimes, based on that statistic that we showed, these patients didn't get here by themselves. It was not solely their choices that led them here. So making sure that you're empathetic with that and understanding that, hey, there was more than just yourself that got you here. And if they have concerns about their pain being uncontrolled when you take them off the medicine, their anxiety being uncontrolled when you take off the medicine, you need to really validate those concerns and have a plan going forward and explain to them like, yeah, I understand that that's a concern of yours, but we can address that. So. sorry, so back to assessing the need. So again, a full medical, psychiatric, and substance use history is really, really important in these because there could be, you could think that it's a medical concern that's causing this, right? I have low back pain, that's why I'm on these medications or something like that. But then you get around to it and really it's not the low back pain that's really causing them. It's their anxiety surrounding the low back pain or the fact that it's going to hurt because in the past they had been uncontrolled and things like that. And so really, are you treating the pain or are you treating their anxiety surrounding their potential pain? So one thing that we have at Jordan Valley that I think is great, so we do have pain management there, and one of the things that is required is that they do have a psychological intake appointment prior to going to pain management. And so that's when they assess all their behavioral health concerns, make sure that there's no underlying mental health disorders that could be kind of compromising their care if they're going to join the pain management program, okay? And then some red flags that may, raise some hairs on your neck to say that, they maybe don't need this medication. So if they're always asking for early refills, so yeah, in pain meds, you could be like, okay, well, they're taking them because they're hurting so much, but that's also not how it was being prescribed, right? When they entered into this agreement with you to prescribe these medications, it was agreed to be taken a certain way. Lost prescriptions. I just recently had a patient reach out to me. They went on a trip, apparently lost half of their controlled pain medication, and then is coming to you looking for, a refill of the prescription. While some of this may be legitimate, there's no way for you to verify that. And so it's really a red flag as to kind of, well, why are you losing something that's so valuable and important to you, right? Inconsistent stories. So one minute they're coming in telling you that their back pain's hurting because of this injury, the next minute it's because of this injury, or their symptoms are changing from appointment to appointment. It really makes you seem like they're trying to game the system and more or less create the symptoms that they need to get the prescription from you. So, and then doctor shopping. I've had patients explicitly tell me that if I'm not willing to prescribe the medication, that they'll just go find someone that will. They know that there are doctors out there, unfortunately, that don't have the same stance that we do, or that were educated in a different time than we were, and so are a little bit more kind of loose with their prescription pad, and they will go find those doctors. So. And then use the tools that you have available to you. So prescription drug monitoring programs are amazing. Missouri has a really good one. So you can log in there, see every controlled prescription that they've had, when it was filled, the indication, who prescribed it. So you can get a lot of information from that.
Are there any difficulties with Missouri docs linking up with the PDMPs from surrounding states?
Yeah, so I have had some difficulty with that. Now, I'll say my knowledge of the PDMP is not super extensive, so there may be ways around it, but I've had some difficulty with that at Jordan Valley whenever I've been trying to get records from out of state.
I have a question with the policy regarding having the patient do a psych assessment before being prescribed. Is that an added cost visit to the patient?
It is not. So it's the intake, it's their initial intake visit. And the reason they do that is because there's a lot of great evidence that group therapy is huge in chronic pain management. And that's one of the things that they implement as a part of their pain regimen. So at Jordan Valley, you get a pain regimen, right? So OMT is a part of that. Having a counselor or psychologist is a part of that. Your chronic pain prescriptions are a part of that, injections, physical therapy. They really try to encompass everything in this pain plan so that they're not missing something. So, but yeah, not at that cost. So. And then make sure always get urine drug screens so you can check for polysubstance abuse. You don't want to be prescribing controlled substances to somebody that already has a substance use disorder. And then ROIs are just release of information forms. Make sure you're always getting all of the records. So at Jordan Valley, we have a policy that at the first visit, a patient sees you if they're on a controlled substance, you do not have to fill that controlled substance until you obtain records from their prior provider and confirm that it is appropriate, essentially. So there's some health systems will protect you from this burden and from this potential risk by saying like, hey, we're gonna back you up and say that like, you don't need to fill this prescription right now until you make sure it's appropriate. So. Oh, it's working now. So.
Oh, is it?
All right, setting boundaries and expectations. So I think this one gets a little bit difficult with patients, and this is sometimes where you just really need to be firm and stand your ground. So the best approach that I've ever found is explain the risks and the guidelines, right? Just be flexible with patients. the amount of people that I come and they come in for just like generalized anxiety disorder, they're on a benzodiazepine every day, sometimes multiple times a day. You know, I can sit down and just explain to them, you know, in the past, we thought this is what was best for these medications. There's been new evidence that's changed that, there's new guidelines that change that, and laying that all out in front of them and explaining to them that owning the medical part of it and say, we are the ones that started you on this and we thought this was a good idea in the past. But now we've increased our knowledge, we've realized that it's not the best option for this and that there are better, safer options out there. And then, so discussing treatment contracts or pain agreements. So this is huge. So Jordan Valley or most places will have a controlled substance contract. And in that contract, it'll lay out, you know, how soon before refills do they need to call? If they miss appointments, then you're not required to fill medications because there is a lot of litigation and things that will surround these. So patients will often tell you that they're going to sue you because you put them through withdrawals and all these things. And you really need to have guidelines set in writing that are signed by both you and the patient that says, hey, we're entering into this agreement together. If we're going to do this, it needs to be by the books. Okay. And like I said, that's really just to protect you and making sure that you're not going to get sued later on. Offering non-controlled alternatives. So this is the part that I think is biggest for me. So, and my approach in controlling or in prescribing controlled medications is that we should always be maximizing the non-controlled options, right? So somebody's coming in for low back pain and all they're on is oxycodone or Percocet for their back pain. And they're not taking anything else. It's like, well, what are we really doing here, right? Tylenol and ibuprofen together, if scheduled appropriately, has been shown just to be just as effective as opioid medications in controlling chronic musculoskeletal pain, right? Lidocaine patches, muscle relaxers, Voltaren, like there's so many different options out there that we have right now that if all we're doing is a controlled substance for pain, then we're doing the patient a disservice. And so this is just kind of an example of a way to kind of set your boundaries. So I want to help you manage your symptoms safely. Let's talk about all the options that we have, and then you just go from there. Handling difficult conversations. So as I kind of alluded to in the past or previously, there's going to be some stuff that comes up, right? There's going to be people that are upset with you. There are going to be people that are claiming to sue you and things like that. So how do you manage that? Well, first and foremost, you always stay calm and professional. If you have done the right research, explain to them the risks and benefits of it, had them sign the controlled substance agreement, if you've done all of the right things, then you know that you're doing the right thing both by yourself and by the patient. And that should give you some solace to be calm and stay professional. This is my job, this is my area of expertise, you know, I know that I'm doing what's best for you, despite you being upset with me. Avoiding arguments. So patients will often try to corner you into an argument where you're going back and forth with them about something that may not be factual, it may be feelings, right? You don't want to get into those arguments because inevitably they're going to remember something that you said or they're going to complain about something that you said. And then that turns into a bigger issue usually, and it can break any sort of kind of relationship that you have with the patient or any sort of move towards a better space for the patient can be completely eliminated if you get into these arguments with patients about things that are in the grand scheme of things unimportant. So, and then offer next steps and follow up. You always want to have a next step for patient. If you're going to take them off of their benzodiazepine, you need to have that next medication that's going to help them. If you're going to take them off of their chronic pain medicine, you need to have that next medication that's going to help them or the next step that you're going to take to try to help them. If you take them off and just say, you don't need to be on this medicine anymore, we're discontinuing it, but I don't have anything else to give you, then that's going to come off as you don't care about them, you're trying to do them harm. Because you're not offering another way to help with their pain or help with their anxiety or whatever they can be on this medication for. All right, when to say no. So some of these signs we kind of talked about earlier. So, you know, losing prescriptions, doctor shopping, all the things like that. So those are pretty clear signs of potential for abuse or diversion, right? So, and then the other one that I think that really goes into this is their urine drug screen. So we have at Jordan Valley, we use a Millennium drug screen. So it is a GCMS breakdown of the metabolites of their urine. So you can quantify pretty much any medication, any controlled medication through their urine on those, right? So you get that drug screen and make sure that they're not having some metabolites from some other medication that they're not telling you about. And then legal, ethical red flags, again, that's what the controlled substance agreement's for. So there are legal things that you are required if somebody's on a opiate medication that can precipitate withdrawal, you really should be tapering them. Right? You can't just pull them off cold turkey because that is causing harm to the patient, right? So there are some ethical dilemmas in this that, for instance, if, you know, even if a patient comes to me and the relationship is broken, we fire the patient from the clinic because of actions that they were doing, I'm still legally obligated to taper them off of this medication for 30 days before, so that they can find another provider. So you wanna make sure that you're abiding by that and not just getting so caught up in what happened, and really making sure that you're taking care of the patient still despite them being upset. And then document everything. Anything from phone calls that the patients had if they come to the clinic and they're belligerent, documenting that, documenting the exact conversations you have in the room with the patient. Everything matters if it comes to litigation. So just make sure that you're protecting yourself, because this is the biggest reason that doctors don't want to be involved with controlled substances anymore, is because of litigation. And then collaborating with others, so making sure that you involve primary care, you are the primary care physician, at least I am in these instances, but if you're not, if you're the specialist that they're seeing, make sure that you're involving their primary care physician in this so that they can help, because oftentimes they have a better rapport with the patient than you if you're the specialist that's just seeing them post-surgery or whatever it may be. Involving psychiatry or psychology is huge as well. Like I said, that there's so many studies out there that prove that chronic pain has a mental health component, addiction, obviously a huge mental health component. And then if you need to, involving pain specialists for other modalities, whether that be epidural injections, corticosteroid injections, things like that. Use your tools that you have to be able to.
When you talk about collaboration with others, like let's say your patient was just discharged after surgery, the surgeon wants to prescribe them like 30 days of oxycodone. How do they reach out to you? Is it just a chart forward to you?
So it depends on the EMR, right? So at Cox, you can just send like a phone communication through Cerner, and you can send it directly to the physician that's there, and it'll be linked to the patient's chart and everything, so you can communicate that way. In Epic, it's a little bit more linked everywhere. So if my patient goes to Mercy ER, and they broke their femur or whatever, and they end up, getting admitted, and then they get out, I'll have documentation of that in my inbox the next day. It'll tell me that my patient went there and what's going on and things like that. So it's really up to the physician that's trying to contact the other physician to go above and beyond to kind of do that. And oftentimes that's just done through discharge notes and things like that, as less so direct communication. Unfortunately, that'd be nice, but just the way medicine is nowadays, it's hard, so. And then use of case conferences or team-based care. So this is something that is a little bit harder to do in practice. In residency, we do this a lot. We all get together, put our heads together about a patient's case and ask each other, well, what would you do in this instance? What would you do? How would you talk to them about this? When you get out in practice, don't forget that most of the time you're going to have colleagues, right? You're gonna have other people that are in practice with you. They may have different practice styles. They may have different experiences in residency and their training, making sure that you're kind of relying on them and still talking to them about what's going on, because you don't want to only know how you prescribe. You don't want to only get kind of tunneled into one way of doing things. So this is some guidelines that I came across about responsible prescribing of opioid pain medications. A lot of this is going to be very familiar and very similar to what we had already talked about, but always discussing the risks and benefits of the medication. The primary one being the potential for addiction, right? You don't want patients to ever think that this medication is not going to cause them an addiction. I'll share with you a bit of a personal story of my own. So I had broke my femur in high school playing football, ended up on opiates for about 6 months due to surgeries and complications that came from that. Didn't realize until I'd gotten to medical school and stuff like that, that I realized that, when I came off of those medicines, because they just pull them off, that's what surgeons do. I had experienced some withdrawal symptoms and a potential little bit of addiction. Now, I was 17 at this time, so it wasn't as big of a deal, but it's not something that you want to just willy-nilly gloss over, right? You want to make sure that it is understood that this medication is dangerous and that it can cause addiction. So maxing out non-opioid therapies first, we kind of mentioned that already. Starting low and going slow. So if this is an opioid naive patient, which means they've never been on these pain medications in the past, the really recommended starting dose is 5 to 10 millimorphine equivalents. You can find that calculator on MD-Calc if you've never had to calculate them. You can go on MD-Calc and it'll ask you a few questions, but you can calculate how much they're getting per dose and how much they're getting per day. Maximum for an opioid naive patient should be 20 to 30 millimorphine equivalents a day. So do not exceed the need. So, if you feel like, so if something is indicated to be treated for 7 days with pain pills, right? But you feel, this patient may need a little bit more, may need a little bit less. It is recommended that you prescribe less of the medication, and if they need more, send in more of the medication than trying to send in more of the medication to get them by or get them through, because then that leaves them with extra pills, which only leads to potential for abuse, or for them to take the medication more. Do not stop abruptly. Again, if you have kind of an ethical obligation to taper these patients if you're going to stop them, and regardless of if you're just stopping them, because you don't want to prescribe them, or if you're truly trying to work towards a taper, the recommended rate is about 10% per month. So that is where they've had the most success. Some people will try to do it faster, but ultimately, usually that leaves people just having increased levels of pain and anxiety that then cause them to go back on the previous doses. So a controlled substance agreement, again, you're gonna hear this from me a million times, it's your best friend, because it really protects you, and it lays out how the patients need to act, which leads me to my next point, and etiquette talk. So every one of my patients that I start on a controlled substance or that I have on a controlled substance, I speak to them about etiquette within the clinic, whether that's talking to my medical assistants and my phone staff, how soon they should be calling for refills beforehand, and that if they are to act kind of inappropriately based on the controlled substance agreements and stuff like that, that there is a zero tolerance policy. And I just do that up front because it saves me that conversation later on down the road whenever they try to push that line, and I document it in the chart as well. And then responsible prescribing of benzodiazepines. So again, always discuss the risk of primarily psychological and physical dependence. The thing about benzodiazepines is they have more than just a psychological effect. So as most of you may or may not know, it's also used in the treatment of alcohol withdrawal, right? So we regularly withdraw people using benzodiazepines. Patients with cerebral palsy or other spastic type paralysis can use benzodiazepines to help with muscle relaxation. So there are other ways that this medication makes you feel good than dealing with your anxiety. And so there's both a physical and a psychological component to this addiction, which makes it a little bit harder to manage. So again, maximizing non-pharmacological measures. This is where your psychologists, psychiatrists really come into play, because they need to be talking with somebody regularly about their problems. If they're having panic attacks or they have trauma that's so severe that they need these medications to function, then they really need to be talking to somebody regularly to make sure that they're dealing with the trauma in a healthier way than just masking it. And then the recommendation is that benzodiazepines only be used for severe and debilitating anxiety, which essentially is panic disorders, or severe and debilitating insomnia. Insomnia I don't see so much. Usually people end up on Ambien as opposed to a benzodiazepine for that. But the biggest one I see is panic disorders. Again, I have so many patients that come to me with just generalized anxiety disorder and they say that they have panic attacks. You really got to dig into what is a panic attack to you, right? If it's just increased anxiety, that's not a panic attack, right? We need somatic symptoms. We need signs that this is truly causing you distress, right? Because otherwise they can be treated with SSRIs, SNRIs, other anxiety medications that don't have that potential for abuse. And then not to be used for greater than 2 to 4 weeks. in an acute setting. So again, you see people on these for life, chronically on these medications, and all that is essentially creating an addiction, whether it be medically necessary or not. And then chronic use limited to as needed but not daily use. That just goes back to the previous point that I was talking about. If someone needs to be on this lifelong because they do have a panic disorder, for instance, I have a patient that had a traumatic brain injury, and now he has agoraphobia so bad that there's times that he won't eat because he doesn't want to go grocery shopping because he's so nervous about going outside, and he will take an Ativan to go grocery shopping. He does it a couple times a week just to get out and go grocery shopping. He's always appropriate with everything. Like, there are legitimate reasons outside of just panic attacks every day or controlling anxiety. So some take-home messages from all of this. So make sure you're approaching these patients with empathy, knowledge, and clarity. These are some of the most vulnerable patients. And if you get them, you have the potential to either really help them or to really harm them. And I think that that's what makes, prescribing controlled substances both a blessing and a curse a little bit, because you do have to take that burden that you could be potentially causing harm to these patients. But I think at the end of the day, if you're doing it correctly and in your heart you're trying to help people, then you can do this safely and you can kind of create a huge impact on some of these patients that maybe have been passed around from doctor to doctor because they couldn't get these medications that they need. Use evidence-based tools and communication skills. That is your best friend whenever you're trying to make sure that you're doing things right by medicine and by yourself. Okay, you want to always make sure that you're up to date on the newest evidence and make sure that you're not practicing 5 or 10 years in the past, because that's easy to do once you get out of residency and get into practice. And then protect your patients and your license. Again, this isn't, I feel like so much about controlled substances looked at as us, right? Like, I need to protect myself. I don't want to go to court. I don't want to get my license taken. I don't want to do this. But also, you got to think about the patients that you're taking on as a provider as well. You're owning that patient whenever you accept them and they are your patient. So you also need to make sure that you're protecting them both from harm from the medication and from harm from not having the medications they may need. Questions, comments, concerns from anyone?
How do you, what are your recommendations for if, say, you're absorbing a patient panel and you have patients that have been with somebody for 30 years, they've been on this potential controlled substance for decades. You're saying, we're trying to taper you down, we want you to be healthy, we want to, how do you convince them to try something else if they're the type that they've trialed everything before? So they have a list a mile long of things that they've tried that just don't work for various reasons. And this is truly what they found to be the only option.
Mhm.
How do you have those conversations with those people, especially when they're more so older?
Mhm.
Because that happened with one of the physicians that I was working with before med school. He absorbed a geriatric provider's geriatric population, and everyone was on opioids or benzos and at ridiculously high doses, but they've been around for 75 years. They've tried everything. So what's the recommendation? Like, how do you approach those conversations?
So sometimes it gets a little bit personal based on the situation, right? But oftentimes I try to remind patients that your pathology evolves with you, right? So if you've tried medications 20 years ago and you haven't touched them or tried them since then, things could have changed, right? Your pathology could change, your mental space could change, whatever is affecting the disease process could have changed, right? So it's worth trialing those again. Now, if it's something that was recent, like they just tried it 4 months ago and it didn't work for them, then obviously that's not gonna work. And there does come a point, unfortunately, with some of these patients where that's what happens. We've tried everything under the sun and this is what they end up on and it works for them. And as long as it's safe and it's meeting their goals, then that's ultimately what matters at the end of the day, particularly in geriatric patients. I mean, you want to avoid medications on the Beers list. I'm sure you all are kind of familiar with that. You want to avoid medications on the Beers list, but also there's something to be said about making sure that these patients are comfortable, and making sure that they have a quality of life still, because as you get older, your quality of life's already being drained. And so trying to provide them with a little bit of quality of life also helps prevent mental health disorders in geriatrics, which can be devastating as well, so. But so it gets hard, I guess, is the answer to that question. It would really depend on the patient, their story and what they've been through. So,
Thanks.
Do you guys provide your patients Narcan or anything for ones that are prescribed?
yes, yeah. So at least in our version of Epic, Epic's built different for every place, but anytime you're prescribing a opioid medication in Epic through Jordan Valley, it asks you if you want to prescribe Narcan, and they'll give you options like patient already has some, patient declines, or go ahead and order it. And so you can order it directly in there, and so that's the standard of care, is that we do co-prescribe them. Yeah. I guess not.
If anybody has any questions online, pop on in.
Well, I hope this was helpful for you all. Like I said, I didn't want to do anything that was too heavy with facts or anything like that, because I know where you guys are at mentally, and we still got an IPU case to do after this too. So I want to save a little bit of brain space, but give you something that can be useful kind of going forward. You all can thank Abby for that. She helped me think of this idea. So, all right, guys. Well, thank you. I guess we got a little bit of